Good morning, everybody. My name's Amerigo Rossi. I'm the president-elect of the Greater New York ACSM, and it is really an honor and a privilege to be able to present Kenneth Perrine. Just looking at the bio, it is long. It's so long that I'm only going to give you all just a kind of a taste of what he has accomplished in his lifetime. And so anyway, Kenneth Perrine received his undergraduate degree from Cornell University and his doctorate in clinical psychology from the University of Kentucky. He was the chief of neuropsychology at the NYU Comprehensive Epilepsy Center and the assistant professor at NYU School of Medicine for over 10 years. He was then the chief of neuropsychology at Long Island Jewish Medical Center for 9 years, as well as professor of psychology and the director of clinical psychology program at Queens College. In 2010, he became an attending neuropsychologist and associate professor of neuropsychology at Weill Cornell Medicine, from which he retired in 2020. He served as the independent neuropsychology consultant to the New York Jets and New York Islanders for 15 years, where he assessed players with concussions and determined when they could return to practice. He has 170 published journal articles and book chapters in concussions, epilepsy, brain tumors, neuroanatomy, and localization of cerebral functions. Dr. Perrine has also been in private practice as a neuropsychologist and forensic expert witness on brain injuries from 1984 to the present time. So it's really a pleasure to introduce you, and without further ado, Dr. Perrine.
Thank you very much. Who was that person? My God. One correction, I don't have 170, I have 103 publications. So a little exaggerated, but still a fair amount of time. Now, what I'm actually going to do is play two videos first, because it doesn't work to have them embedded within the presentation. So there. Okay, perfect. Sure. This mouse is hypersensitive. Where'd it go? There it is. Okay, I'm going to play a couple of concussions. This first hit is from an NFL game, or actually it was a college game, NCAA. You'll see a cornerback or safety intercept a pass and then make a wonderful run and then get nailed by a 6'11", 340-pound offensive lineman. Because he was playing defense, he was up against the offense, and the offensive lineman nailed him. So look at this hit.
Looks downfield, jump ball, and
here's the interception.
Diamond Berry, who's been busy today, has the interception.
Heck of a run, good blocking, and wham!
What a huge hit!
Look at the size of the guy that hit him.
Might be a defensive lineman. Whoa! And that hurt him. That Diamond Berry.
Now this is a typical concussion that I might have seen working with the Jets or with the Islanders.
In full speed. I think that
where there's no loss of consciousness, obviously,
there, but you're no lineman that size. You take one shot at it.
One will review, and then I'll go into the next video.
You take one shot at a hit. If you get lucky and make contact, you do, and this is square.
Watch the back of his helmet. Boom. He probably got it from two things. One is a helmet-to-helmet blow, which is bad, and the other is his head hitting the turf.
Words on the contact.
Against this, okay. And the other one. This is Tom Savage from the Kansas City Chiefs.
Now look at Savage too. He's driven into the turf, and look at him. Now, that hurts. Anytime you get the hand shaking and stuff, you always worry about, did his helmet hit the back of the turf? Is there potential for a concussion? We can't see it here because the ref is in the way. But anytime I see this with the stiffness and see the hand shaking, that is a potential concussion. Let's see the back of the helmet. See how it hits right there on the turf? They're
Does
talking.
anybody know what that's called? It's a very specific term for it. It's called an impact seizure, which occurs right at the time of impact of a concussion or head injury, and is usually a generalized tonic-clonic seizure, a grand mal seizure. In this case, it wasn't. It was just his arms that were going. And oddly enough, this guy wanted so bad to get back into the game, he actually ran onto the field. They had to go get him. They brought him back, and they eventually took his helmet away to keep him from playing, which is very, very common for NFL players. Yeah, slideshow from beginning. Got it. Thank you. Okay, a couple of quick disclosures. I was with Weill Cornell Medical College in the Department of Neurological Surgery for about 15 years altogether, and also had been the concussion doctor for the New York Jets and the New York Islanders until this last season, and still do some consultation with them. I also do expert witness testimony and independent medical evals for traumatic brain injury in litigation cases, disability, Social Security, variety of different venues. All right, a concussion. Lest there be any doubt, this player obviously has a concussion. Look at his face. Lights are on, but no one's home. Kind of a classic presentation. And I love this slide, except the Cubs actually won, so it's no longer quite as relevant. But for one brief, glorious moment, he forgot he was on the Cubs. All right, so what is a concussion? And there's a lot of variations between different organizations in terms of what constitutes a concussion. And different definitions have been put out by the American Academy of Neurology, various neurosurgery organizations, physical medicine and rehab, DSM-5 from psychiatry, the National Institutes of Health, and the World Health Organization. And they primarily differ in terms of how long either the presence of or how long there is loss of consciousness and amnesia, what the Glasgow Coma Scale is, and what the findings are on neuroimaging. How do I get rid of that thing in the corner? What? You can't? Okay. Interesting. How many people know what a Glasgow Coma Scale is? Okay, you will. It's a scale of assessing real coma, going from completely out to fully awake and alert and conscious. Now, probably the best definition was put out by the Sport Group meeting in Berlin in 2017. They came out with a consensus statement that was published in the British Medical Journal. And it's comprised of a TBI induced by biomechanical forces, direct blow to the head or transmitted to the head. It can be hit someplace else, but if you have your head involved, it can cause a concussion. Rapid onset of brief neurological impairment that resolves spontaneously. The symptoms may evolve over minutes to hours and occasionally, rarely days, usually the next day. The acute symptoms reflect functional, not structural injury. An important thing to understand is that a concussion is not damage to the parenchyma of the brain, to the actual brain substance. Instead, it's a functional impairment of electrolytes and neurotransmitters. No abnormality is generally seen on standard neuroimaging, and there are lots of signs and symptoms, which we'll see momentarily. And there's resolution with a sequential course. It's very rarely prolonged, and it has to not be due to substance abuse or other comorbidities. So here's the range of symptoms that we see in concussions. Almost everybody divides them into 4 different categories that are denoted by the columns in the slide. Among the most common are headache, balance problems, fatigue, sensitivity to light or noise, photophobia or phonophobia, feeling kind of foggy. People describe brain fog, actually. It's a commonly used term by the patients. Poor concentration and memory, slowed responses, repeating things, confused. And then emotionality is fairly common, irritability, sadness, nervousness, anxious. I've had some NFL players who actually came to the sidelines and started crying, just boom, out of the blue. Not necessarily because they've been knocked out of the game, just more emotionality. It also affects sleep, including drowsiness, sleep onset insomnia, sleeping less than usual, and sleeping more than usual. So factors affecting whether or not you get a concussion and how bad it is, it's the number and severity of the symptoms, the presence of a recent concussion, and we'll talk about second impact syndrome in a bit. The concussion can be from less impact than a prior one, and comorbidities, and this is very important because they really drive prolonged recovery, are a history of migraine, mental health disorders, attention deficit hyperactivity disorder, learning disabilities, and sleep disorders. And the use of psychoactive drugs or anticoagulants can exacerbate concussions. Now, typically what we see is a period of what's called retrograde amnesia. So suppose you sustain an injury right here. Whoop. Is the mouse showing up on the screen? Okay, good. So this period is the actual hit. And typically we'll see a little bit of retrograde amnesia, meaning amnesia for a period of time preceding the hit. So they may not remember leaving the house, have zero recollection of that. Then after the hit, even if they have not lost consciousness, they may not be laying down new memories. And that is called post-traumatic amnesia. Very important because it's one of the best predictors of how long a concussion stays symptomatic and the length of time of recovery. Once that post-traumatic amnesia ends, the patient's able to lay down new memories. Now, when you take a history, it's a little confusing because a lot of patients will report that they were unconscious for half an hour because the first thing they remember is coming to in the emergency room. But that's not true. What they were experiencing was post-traumatic amnesia. They took a hit, they lost the ability to encode new memories, including for the ambulance ride and the initial arrival at the ER. And so you can't rely on the patient's description of how long a period of loss of consciousness has lasted, because it really depends on the post-traumatic amnesia. What's really striking, if I see somebody in litigation or for disability, they'll say they were unconscious for 2 days and had amnesia, but yet at the same time, they'll describe in horrific detail the sound of the impact, the flying glass, the blood, all in hopes of kind of upping their award. Okay, now a mild TBI is a little bit different than a concussion, according to some definitions. Again, it depends on which of those organizations are issuing the definitions. But for the most part, a mild TBI is positive neuroimaging, a skull fracture, a subdural hematoma, which is bleeding between the dura, which is a tough membrane surrounding the brain, and the brain itself. It doesn't invade the brain, it just presses on it. A subarachnoid hemorrhage, which is one step down from a subdural, between the arachnoid membrane and the brain itself, but again, it's not into the brain. An epidural hematoma, which is extremely serious, that's a rupture of an artery, typically the middle meningeal artery, that results in pumping of arterial blood. And that results in mass effect and oftentimes herniation. Loss of consciousness for more than 1 minute puts it into the category of a mild TBI, and then more prolonged retrograde or post-traumatic amnesia. You do not need to have loss of consciousness to have it called a concussion. Most people who have one describe at most a brief loss of consciousness if they don't have too much post-traumatic amnesia. Now, our athletes, my Jets and Islanders, will describe having their bell rung, a ding, seeing stars. Those may or may not be concussions. Elite athletes say they can kind of tell the difference. A ding or having your bell rung, usually in football, the player's able to get up, go, whoa, that was one hell of a hit, and then go back to the huddle and kind of proceed as normal. Seeing stars, a little bit more, and then if they feel like they're off in whatever way, they know the difference. And if you ever talk with an NFL player, they'll be able to describe it. The retrograde amnesia is usually pretty brief, usually constituting maybe a few seconds to a few minutes, but it can be very prolonged. I've had patients with retrograde amnesia extending a day or two, and not in concussion, but in severe head trauma, even longer. Post-traumatic amnesia can be longer, remembering only the emergency room. If it's a Jet or Islander, they might remember everything up until or after the plane arriving home. They won't remember the plane flight. And they have a lot of post-concussion symptoms, obviously. So the range of mechanisms, oftentimes it's from a motor vehicle accident or in a sport where the patient has hit his head or her head directly or after a fall to the ground, like you saw with the NFL player with the seizure. Whiplash, boom, can cause a concussion. Falls, assaults, and collisions of material with the head also can. Then there are a group of patients that don't really have concussions, but think they have concussions. And I've had a lot of patients come into the concussion clinic at Cornell saying that they banged their head on a bookshelf or a desk when they were standing up, ran into a chin-up bar, banged their head on the headboard in bed when they were sitting up. My all-time favorite was a patient in litigation against a grocery store who said that boxes of Cheerios landed on her head and caused her a concussion. Think about that for a sec. How much does a box of Cheerios weigh? Well, she didn't get very far in her litigation. The pathology, again, is not damage to the brain per se, can include it, but that puts it into more of the mild TBI category. Instead, it's a cascade of neurochemical changes. It can include some edema, some swelling. These next ones pertain more to mild TBI or more severe concussions, including subdurals, epidurals, diffuse axonal injury, which I'll talk about in a second, and skull fractures. Ironically, skull fractures produce less concussion syndromes than non-skull fractures. The reason for that is the skull acts as a crumple zone. So if your skull is fractured, it absorbs a lot of the impact that otherwise would have been directed to the brain. So a lot of our patients in neurosurgery that had skull fractures have fewer symptoms than those who don't. This is a slide that really describes more mild TBI or moderate TBI, where there's been a blow to the head, a contra-coup blow directly opposite the initial blow, including some rotational forces and some contusion, swelling, and a blood clot. Somehow just went to that one slide. Heather, help. There we go. Okay, so diffuse axonal injury is damage to the axons, which are sort of the wires connecting the neurons in the brain. And it includes a tear at the base of where the axon meets another axon to form a tract. And focus down here. This is a normal axon. There's the gray matter, the mantle covering the brain, and then the axons coming down from it, which is white matter. And shearing or rotational forces can stretch and damage the axons where they leave the neuron. And it can include tangles, tears, and a broken axon. And this can happen in concussion. It's a matter of debate, really, among a lot of experts. It's probably a little too much detail. This is what diffuse axonal injury looks like on an MRI. How many of you have seen an MRI of the brain? Wow, okay. Hopefully you'll see more of them. This white matter schmutz right here is a little dot of what is called, and if you see a report of it, an area of increased T2 flare hyperintensities in the brain. And what it is a white spot. And it can represent either diffuse axonal injury, but it can also represent multiple sclerosis. It can represent little tiny, tiny strokes that are very common as people age. Most people over the age of 60 have a few of these, which are very microscopic strokes, but they do show up on MRI. Okay, this is what it looks like biochemically. After a hit at the very beginning, there's a very rapid and gross influx of calcium into the cell. The cell membrane is disrupted, allowing the flow of these electrolytes that ordinarily would not be coming into the neuron. There's an influx of potassium. Glucose sometimes does a little dip, but then will increase over the course of a few minutes and then gradually start declining. Glutamate also, initial rise and fall. And CBF is cerebral blood flow, the amount of blood going to the brain. And right after the hit, it can go down and then extend for a period of time. It's one of the last things to come back, actually, along with the calcium. Don't want to talk about this too much, it's a little too technical. Hypermetabolism often occurs right after the initial impact. The brain tries to restore balance because the mitochondria, which are producing the energy in the cell, are affected from the influx of the calcium. And that requires more glucose coming in. So the brain will compensate by increasing the amount of glucose. The use of energy results in lactate production, and the blood flow to the brain stays reduced. Third stage is glucose initially rises a little bit and then dips. That decrease occurs usually 1 day post-injury, and it can remain for days to weeks. And as I mentioned, blood flow may last for days. And the hypometabolism is really not related to the level of consciousness or loss of consciousness. Now, some differences between different groups. Children and adults and gender make a difference. In children, sports are the most common. In adults, motor vehicle accidents are the most common. Although the neurophysiologic effects are similar, especially in terms of the biochemical reaction, but the symptoms and recovery differ markedly. Children have more behavioral symptoms, acting out, irritability, things of that sort. And they often have a longer recovery than adults do. Adults show more physical and cognitive symptoms, headache, vertigo, diplopia, things of that sort, and memory and concentration problems. Associated factors that affect it include, for children, going to school, interaction with peers, and how their families are treating them. And in adults, it's work, family responsibilities, activities of daily living, and what they do, and oftentimes litigation, which I'll talk about momentarily. Gender differences, there's a higher frequency of concussion in females. And some of that may be due to women being more prone to report concussions than men, who are more likely to cover it up and say, no, I'm fine, put me back in. There's less of a cover up in terms of returning to play or other activities. And adult women also have more responsibilities, especially childcare, and that can also prolong recovery. Risk factors for children include prior concussions, the things I mentioned before of LD, ADHD, other psychiatric disorders, a period of extended post-traumatic amnesia, not remembering being in the emergency room, bad sign. Younger age, we know that children's white matter, the axonal processes in the brain, are not fully myelinated until about age 12. But that myelination goes on well up into the early 20s. So the myelination affects the speed and efficiency of transfer of the potential across the axon. And if it's not fully myelinated, it's going to slow things down. Children also have psychosocial and family issues. They're often still a little foggy at 1 week. And again, emotional symptoms are more prominent than the cognitive or physical ones. Other factors affecting children is denial in hopes of returning to play, especially for athletes, motivation to be excused from school, and the attention they get that will sometimes result in prolonged symptoms, meaning they'll stay symptomatic to stay out of school. There's what I call chronic fetching syndrome, which is people that complain about this hurts, that hurts, I've got a headache, I've got balance problems, I have vertigo problems, and so forth and so on. That is very common. And at the concussion clinic at Cornell, I would say the majority of the patients we saw had this sort of somatization disorder. Then another factor is litigation or seeking accommodations. In children, that can include accommodations for things like the SATs, ACTs, finals, things of that sort. But you want to really suspect that there's something amiss if the child is saying that they have autobiographical amnesia, meaning that they have forgotten periods of time from years before the concussion. And that can be very, very prominent. Doesn't happen just in children, also happens in adults. Bottom line is you don't forget things from a long time ago. A lot of patients think that the longer a period of time has elapsed since a memory being formed, it's going to be more susceptible to forgetting. Wrong. It's a more recent memory that is susceptible, not the long-term memory. So if somebody who's, say, a senior in high school doesn't remember anything about their elementary school, can't tell you where they went, can't tell you a favorite teacher, things like that, suspect that something's a little bit off there. Also, having the patient reporting to you differing dramatically from their history, from medical history or the parent's history, is another key to suspecting symptoms being a little shaky. Concussion recovery. Most uncomplicated concussions resolve within 1 to 2 weeks, and at most up to about 6 weeks or so. If more than a few symptoms are present at 6 weeks or more severe, consider having them evaluated at a good concussion clinic at one of the major medical centers. Complete cognitive and physical rest used to be the most common treatment for concussions. Lay down in a dark room, draw the shades, don't turn on the TV, don't use your cell phone, don't watch TV, complete cutoff from other activities. It was referred to as cocoon therapy. And that is no longer found to be beneficial, and in fact, can exacerbate concussion symptoms and prolong them considerably. So instead, we tailor rest to the symptoms. If an activity produces or exacerbates symptoms, back off from it, tell them to cool it a little bit. But as recovery progresses, increase it. And I'm going to be showing you the protocols that we use in different venues. So this shows a recovery curve after moderate to severe TBI. So this is a severe one where there are positive findings on neuroimaging, subdurals, subarachnoid hemorrhages, and intraparenchymal hemorrhages, contusions, and so forth. And there's a very rapid improvement over the first 6 weeks or so. It then, if you remember from your math what the slope of a curve is, it's this part right here. The slope decreases in the next 6 months and then goes on and gradually improves, and improvement can continue well out to pretty long, after 3 to 4 years. And I've had patients with severe TBIs that I thought there would be no way in hell they'd be able to return to work. After 3, 4, 5 years, they turn the corner and they get better and are able to resume work or school, whatever it might be. Concussion is a lot different. Instead of it being months after an injury, it's days post-injury. So again, the most rapid recoveries in the first 4 days, leading up to 8 days, up to 12 days, and then it slows down quite a bit, but doesn't stop, continues out to about 24 days, or about a month or so, month and a half. And generally after that period of time, the symptoms are pretty much gone. Now, oftentimes this is exacerbated by physicians, iatrogenic exacerbations. An internist, a pediatrician, or other healthcare advisor tells the person to do cocoon therapy. Again, lay in a room that's dark, lights off, no sound, no TV, no video, no cell phone, no computer, et cetera, and will advise not going to school for a certain number of days or weeks. But this is in contrast to any other medical disorder. Disorders of back injuries, of orthopedic injuries, a lot of other injuries, they don't advise complete rest. They prescribe perhaps brief period of rest, but not complete cocoon therapy. And there's no research showing that complete rest or cocoon therapy helps speed up recovery, none whatsoever. And in fact, it's just the opposite. It can feed into that chronic fetching syndrome, or still experiencing a bunch of things that might be concussion related, but might just be a matter of daily living, like getting tired during the day or having a headache or normal sorts of things. And this can result in the injured person inadvertently assuming a sick role. And that is something that we really battle against. Not well-intentioned is greed. Patients who are in litigation or are seeking disability or workers' compensation. This is the summary of a patient I saw in litigation who fell down a flight of stairs. There was no loss of consciousness, no amnesia. She remembered the fall. She remembered hitting. She remembered what happened immediately afterwards. 6 months later, way after a concussion resolves, she went to one of the major medical centers in New York, to the concussion clinic, where she had a brief neuropsychological screening, which was abysmally too brief. And she was then placed on OT, speech therapy, cognitive remediation, vestibular rehab, and had no symptom improvement whatsoever. She was administered a full neuropsych battery after starting treatment, which is rather bizarre, with a ton of scores generated from the tests that were administered. And of the tests administered, probably several were near chance, i.e. if you give too many tests, you're going to find one that's abnormal. And that's what happened with her. And also the person writing the report interpreted scores at the 50th and 34th percentile as being either reduced or poor, which is dead wrong, according to psychometrics. And then 2 years later, she was seen as part of litigation against the building where she fell. And I see this a fair amount in the independent medical evaluations I see for TBI. It's really quite striking. Now, switching over to sports medicine, assessing concussion on the field. How many of you know what a SCAT-5 is? Oh, all right. How many of you are on the sidelines during a sport? All right, well, that would narrow down why you haven't seen the SCAT-5. The SCAT-5 is administered on the field or after taking a player off the field. It's a brief but comprehensive assessment of concussion. Can be given partially with any concussion and yields a quantitative score that can be tracked over time that's very, very useful. It includes the sideline assessment of concussions, which includes a word learning test, learning a list of 4 words over 4 or 5 trials, so-called Maddox questions. What's the last team we played? Did we win or lose? So getting at that period of retrograde amnesia. A symptom checklist of 22 of those symptoms from that chart I showed earlier, broken down into physical, cognitive, emotional, and sleep symptoms. And they're graded on a scale of 0 to 6. Anybody know what that scale is called? Where you rate something 0, 1, 2, 3, 4, 5, 6. Wrong. It's Likert. Believe it or not, Likert's son went on talk shows saying, I am so sick and tired of people calling it the Likert scale. Our family name is Likert. It's the Likert scale, which was pretty amusing. The SCAT also includes the balance error scoring system, where hands are put on the iliac crest. Patient is asked to lift up one leg, and you look to see any loss of balance over a period of 20 seconds. Second one is a tandem stance like that, and the other is just feet together. So it's pretty much what the cops do when they're stopping somebody for drunk driving. Also, it includes a timed finger to nose test, how quickly you can conduct a finger to nose test, and a timed tandem gait. So walking in a tandem stance over a fixed period of time that is timed. Very sensitive test to immediate symptoms of concussion, very, very helpful. Now, when to go to the field or when to go to the ER off the field, any headache that worsens, drowsiness that cannot be woken up. Drowsiness is pretty common, but if you can't wake the person up, that's a bad sign. Not recognizing people or places, repeated vomiting, a little bit of vomiting and nausea is common after a concussion, but repeated vomiting is a bad sign. Confusion or irritability that worsens, seizures like that video I showed you, weakness, paralysis, numbness, or other neurologic symptoms like that, feeling unsteady on their feet and having slurred speech. Then it's time to go to the emergency room. Now, doctor's visits often do not do what they should. Ideally, a sports medicine doctor will take a history that includes what's the last thing you remember before the hit, retrograde amnesia? How long were you out? And looking for corroborative sources from medical records or family members, whatever. What's the first thing you remember after the hit? That's post-traumatic amnesia. And then a list of the concussions that can be taken from a checklist that's frequently used and as part of the SCAT. Doing a detailed cerebellar and examination of extraocular movements, the presence of nystagmus, oscillation of the eyes on lateral gaze, or other problems moving the eyes or a tip-off to something that's going on. And then reviewing concussion with the player and family, handing out the CDC fact sheets. The CDC has a wonderful sub-site called Heads Up that describes concussions very well and also describes what to do after sustaining a concussion. It's a very good website. MDs often will restrict patients from work or school, but they should be doing that only if it's really necessary. And unfortunately, again, a lot of physicians do it a little too frequently, and then they'll schedule a follow-up appointment in several weeks. I have found that the MD office visits are among the least effective and least knowledgeable about concussions and give me the least amount of information. After the first few days, a little bit of rest, not cocoon therapy, but a little bit of rest, and avoiding strenuous activities if the symptoms worsen. No alcohol or drugs, no sleeping meds because they can mask things that could infer an exacerbation or a worsening of the syndrome, like bleeding in the brain. Avoiding aspirin or non-steroidal anti-inflammatories like ibuprofen, because they can also mask bleeding, and avoiding driving until the symptoms improve, and no strenuous exercise until symptoms improve. But here are the protocols that we follow. The National Hockey League, all the athletes do computerized impact testing. How many of you know what the impact battery is? Wow, that's a surprise. I would have thought more would have. It's a computerized battery that takes about 25, 30 minutes, covers attention, concentration, memory, but the reliability statistics of it are terrible. And it's not the most reliable test in the world, but it's better than nothing. So we do that on all athletes at baseline. And then after a patient or a hockey player has had a concussion previously, either that season or the previous season, we do full neuropsychological testing with them. In the National Football League, the impact is conducted by the trainer and on every single player. And for 15 years, I was one of about 2 neuropsychologists in the country that was administering full paper and pencil neuropsychological testing at baseline so that I would have something to compare their performance after a concussion to, because there's a lot of variability in how well people do. So that has now become de rigueur. The NFL has now required neuropsychological testing at baseline every 2 years, which is a very good idea. And then for both sports, the athlete is encouraged to go to the facility maybe one day after the concussion to do some stretching and very light exercise, maybe walking on a treadmill at a low rate, engaging in very light exercise. Then they'll progress gradually, as long as they're not symptomatic or not worsening their symptoms, to heavier exercise. So with the NFL, it might be after 3 or 4 days, they'll start lifting. But again, if they start to get symptomatic, they back off. And we go back one step. There's 5 steps altogether to resuming play and practice. And the practice is engaged in only after they're symptom-free and have normal neurocognitive testing, both paper and pencil and the impact battery. And as they ramp up, they get more intense exercise and practice on the field, but without contact initially. So in football, they'll put on their shells, they'll dress normally, but they won't have any contact with other players. Or they'll do position-specific drills. For instance, a cornerback might practice running backwards, sideways, forward, sideways, backwards, and so forth, emulating what they do on the field in regular play. And this graduated return, and it's worth going to the website for the NFL to look and see the more details of what they do. But it's really gradual. And the bottom line is if they get symptomatic, you back off. So while the patient is still symptomatic, some rest, limiting, if it's child, school, reading, video games, a little bit, but to tolerance level. If it's not bothering them, there's no reason to limit it. Then gradual escalating exercise. Again, only if they're asymptomatic. So it can include riding the exercise bike. In the NFL, they will start off with 5 minutes at 120 beats per minute, and then they'll ramp up to 5 minutes at 150 beats per minute of their heart rate. So they'll gradually increase the exercise. They'll go into wind sprints, then non-contact drills with full equipment and lifting, and then limited controlled return to contact and practice as long as it's supervised, and then finally returning to play. And the mantra here is, when in doubt, sit them out. If there's any question about symptoms still being present or getting worsened, you want to sit the patient out. Risk factors for extended recovery. Let me speed up a little bit. We've talked about prior concussions, long post-traumatic amnesia, being younger, foggy after 1 week. Psychological factors, cognitive compromise, attention, learning, memory, can create a shaken sense of self. I'm not myself anymore. And that can really exacerbate the symptoms just from the patient being worried about it. Can result in depression and anxiety, and that overlays what's already there from the concussion itself. And we've already talked about that. A couple of controversies. How many people have heard of second impact syndrome? Wow, my God. Second impact syndrome had been hyped as you have a concussion. If you had a previous concussion, you die. And the mechanism for it, I'll talk about in a sec. The other is chronic traumatic encephalopathy. How many of you have heard of CTE or seen the movie Concussion with Will Smith? Okay, CTE is something that's a little controversial. And a lot of the people writing about it aren't writing about the truth. The worst example was a guy named Gary Schwartz, who is the writer for the New York Times about sports-related injuries. He had a front page article, not on the sports section, but front page of the Times, that led to a Pulitzer Prize nomination. Turns out I had seen the player he was highlighting twice, and he made multiple mistakes in his reporting. So I wrote a letter to the editor with the permission of the Jets and the player, and they never published it. It's because that media hype is more important than the truth. Second impact syndrome is a second concussion before the first concussion has fully healed. It's marked by rapidly progressing cerebral edema. Brain swells inside the skull, has no place to go, herniates down and through the foramen magnum, compresses the brainstem, kills the patient. It's the most common in adolescents and children. Fortunately, the prevalence is not that high, but it does happen. But there's no evidence that it results from a second concussion. Any ER doc will tell you that a single concussion can cause that rapidly progressing cerebral edema and death. But it's been hyped as being, you can't send them back too soon or else they're going to die. CTE is dementia that is caused by supposedly either multiple concussions or subconcussive blows. Used to be called dementia pugilistica. For those of you that saw the movie Concussion, was first described by Amalu, and then taken over by the Boston group, a neurosurgeon named Bob Cantu, Ann McKee, and Bob Stein, neuropsychologist, that claimed a really high frequency in retired NFL players. And it's also seen in other contact sports, especially things like soccer, where hitting the ball can do it. But it's very controversial. Ann McKee would go running to the press every time she did an autopsy on a brain and found CTE. But a telling example is this one right here, where Aaron Hernandez, that people may remember, was reported to have had advanced CTE, not seen in a brain younger than 46. But Anne forgot to mention that she published a report of finding CTE in a teenage football player. So a little shaky. The cases in which CTE is not found are not publicized. And there are very few studies of non-athletes. Brains of regular people don't get sent to Boston for an autopsy. It's usually families of retired NFL players who are suing because they think that the multiple concussions caused their loved one to kill themselves or die of dementia. But in their behalf, Cantu, McKee, and Stein are now trying to recruit non-athletes through an NIH-funded study, very large study. And that's it. Questions?
Are you seeing more technologies like a mouth guard or something in the helmet to gauge impact? And even if there's no symptoms, taking them out from the.
The first part, yes. The second part, no. Yeah, there are a lot of technologies that have included accelerometers and other transducers inside helmets and football to measure the amount of impact. Tell me, how many G's, you know what a G is, gravity. How many G's do you think an impact will cause in football?
I couldn't answer that.
Take a wild guess.
2.
70 to 120 G's.
Oh, it's close.
It's incredible, the amount of G forces. And the accelerometers have proven this. But they don't cause concussions necessarily. So we don't rely on that technology. And there've been a ton of mouth guard accelerometers and transducers, ones inside the helmet. There's a lot of companies hyping all this. And it's of questionable reliability and questionable validity, because really the bottom line is the player symptomatic? You know, are they having concussion symptoms? That should be your guide, not so much what the technology says.
Thank you.
Yeah.
So the impact testing that you described earlier, like in the NHL? With the impact testing that you described in the NHL and perhaps other leagues, to what extent do you think a problem could exist where players, you know, where they're in motivation to get back ASAP, to sort of underperform on the initial baseline intentionally?
Oh, that happens. And when I do the baseline testing, I bring out some colleagues, usually some graduate students, to watch them like a hawk and make sure that they're really concentrating and really trying. Because yes, they will try to do somewhat poorly on baseline so that when they get a concussion, they'll do better and then return to play. Because elite athletes don't want concussions. They don't want to be let off. They want to get back in there. And it's not because of money. These players are so motivated. It is unbelievable testing these guys. The NFL, for example, when I'm doing digit span, gonna rattle off a string of numbers, repeat them back to me in the same order. We'll go, wait, doc, wait. Okay, go ahead. Their expectations and their motivation is just incredible. So they don't sandbag it at baseline. The Islanders tend to sandbag a little bit, so we have to watch them a little bit more. But the NFL players know what the consequences are, so they tend to be a little bit better. There's also validity measures built into the impact to see whether or not somebody's really been trying. Other questions? Yeah.
Have you found that?
If there are any questions for those who are on Zoom, you can just raise your hand and then we'll see if we get a call on you.
Have you found that players that are prone to migraines and say tension headaches and/or have mental health disorders take a longer time to recover once they have a concussion, or is it around the same?
Yes. Those pre-existing conditions do affect the length of recovery. Not always. You know, there's plenty of players that have, you wouldn't believe the number of NFL players that are on antidepressants, for example. You know, before I started doing this, I wouldn't have thought that. But yeah, a lot are. A lot have family issues. A lot have other things going on that can affect the recovery. I went out to see an Islander once who was described as having this whole gamut of concussion symptoms. Got out there, turned out his wife had left him the day before. And that was driving his symptoms, not so much the concussion he had. So things like that can obviously affect recovery. Yeah.
Are there any nutritional supplements that can help speed up the healing process of a concussion or anything like that?
Been a lot of people trying to find kind of a magic bullet that'll help speed it up. So far, nothing has really panned out in really well-controlled, random assignment, placebo-controlled, double-blind studies. Most of them have been anecdotal. That being said, we never say to a player, don't take a supplement, don't take a whatever. Go for it. If it might help.
Phosphatidylserine, because that's supposed to be like good for the brain, memory, that type of thing like that. And fish oils.
Fish oils actually are on the borderline. There's some evidence that they really do help, and they help memory, period. A lot of doctors are taking fish oil now to ward off incipient dementia. I take fish oil. So some of them are, there's a little more evidence for it. But my mantra is, if it can't hurt, it might help. And the placebo effect is very powerful. So if people are taking supplements and think that it's going to help them recover faster, they will. And why not? No reason not to. Others? All right. Very good.